Starting first with the dry eye syndrome. So what is the dry eye and what is the syndrome? How to diagnose it? How frequent is it? And how to manage it? So first of all, let's have a solid definition about what is dry eye. A dry eye is a condition where there is inadequate tear volume or function, resulting in unstable tear film and ocular surface disease. So you may consider, or for many instances, you may encounter a patient who is telling you that, doctor, I have a burning sensation in my eyes. And when you examine him, you will find that, or he is saying that he is having burning sensation. And when you're telling him, or you are telling him that he has dry eye, he tells you that I already have overflow of tears. So does this overflow of tears contradicts with the term of dry eye? No, because it is not only about the volume, it's also about the function. So when there is when there is a problem in the irritation coming from any stimulus, or there is an abnormality in the ocular surface, there could be a reflex tearing. This is just to correct the overall problem. So it is not like a dry eye. We can more accurately term it like a tear film dysfunction. It is more of a tear film dysfunction rather than only a volume. So to back to basic, we know that the tear film is secreted from the lacrimal gland that will pass into the from the fornix, the upper fornix, into the causing wetting of the corneal and the conjunctival surface, and pass through the sharp edge of the lower lid until it is excreted through the puncti, the upper and lower punctum, more to be like 80 or 90% from the lower punctum and the remaining from the upper punctum. Then it will be excreted through the lacrimal system. And this tear film is composed of three layers: the mucin layer, which will be the inner layer toward the eye, and then most of the tear film is made by the aqueous layer, which is secreted from the lacrimal gland, and the lipid layer, which is the outermost layer, which is secreted mainly by the meibomian gland, while the mucin layer is secreted by the mucinous glands, such as goblet cells present in the conjunctiva. So if there is any problem affecting any one of these resources of the tear film, it can result in a dry eye syndrome. If there is any problem affecting lacrimal gland, such as an autoimmune disease causing such as rheumatoid arthritis or so, can cause autoimmune antibodies against the lacrimal gland. It will affect the aqueous layer, causing dry eye. If there is any chronic blepharitis or disease affecting the lid, affecting the meibomian glands, which are the main source of the lipid layer, it will cause also a dry eye, causing overflow of tears over the eye. If there is a problem affecting the mucinous layer, like if there is any destructive lesion affecting the conjunctival surface, as all cicatrizing disease such as chemical burn, Stevens-Johnson syndrome, ocular cicatricial pemphigoid, trachoma, all this will affect the conjunctival surface, causing scarring of meibomian of the mucinous glands, leading to or goblet cells, resulting in also dry eye. So this will be it is not only about the volume, it is also about the function of each layer and its source. If there is affection of the function or if the affection of the source, this will result in dry eye syndrome. So to summarize the etiology or to categorize the etiology, we have two main categories. It could be a decreased tear production, or there is excessive tear evaporization. This is for the volume. This is when there is affection of the volume. The decreased tear production, it can be due to what's called Sjogren syndrome. Sjogren syndrome, which can sometimes be primary in the lacrimal gland, causing decreased lacrimal secretion. Or it could be secondary, and in secondary to rheumatoid arthritis or systemic lupus erythematosus or Wegener granulomatosis. So this will be the causes of the Sjogren syndrome. Non-Sjogren syndrome is when there is a decreased lacrimal production. So what are the causes that may result in decreased lacrimal production? It could be like congenital absence or hypoplasia of lacrimal gland, or congenital atresia of the lacrimal gland canaliculi. It could be idiopathic, could be infiltrative by tumor. It could be secondary to radiation or surgically induced by accidental removal, or lacrimal obstruction by Stevens-Johnson syndrome, ocular cicatricial pemphigoid, trachoma, as we just mentioned. Reflex post-medications or post-surgery, it will cause irritation of the ocular surface with reflex tearing. The excessive evaporization is the second etiology, which can be due to meibomian gland dysfunction, as the meibomian gland dysfunction will affect the lipid layer, and lipid layer is the layer which is responsible for decreasing the evaporization of tears. So this is very important. Why those patients who are giving them artificial eye drops, they will still complain of dry eye or complaining of burning sensation, because these these artificial tears, they don't sustain for so long on the surface of the eye. They don't have this lipid layer. So this lipid layer will protect the tear film from the rapid evaporization. Also, if there is lid disorders causing excessive tear evaporization, like if there is cicatricial ectropion, for example, with overflow of tears over the cheek, lid closure and the blinking disorders, if there is like coloboma or any defect in the lid, any blinking disorders causing abnormality in the blinking will also cause excessive tears evaporization. Dr. Islam, source of aqueous layer, the lacrimal gland or accessory, both of them, but the main part is from lacrimal gland. Okay, so this will be the etiology of a dry eye. So what will be the manifestations of dry eye? What will be a patient who has dry eye will be complaining of? Basically, a lot of symptoms, including burning sensation, stinging, itching, tearing, sandy or gritty feeling, scratchy or foreign body sensation, discharge, frequent blinking, mating or caking of the eyelashes, which become more worse on waking. You will hear all these symptoms from patients with dry eye. Redness, so they will be having chronic redness of the eye, blaring or fluctuating vision. This is also very common symptom that, or very common complaint, that those patients report that they have fluctuating vision. The vision is becoming more worse on reading, computer, watching television, driving, playing video games. All these demanding tasks may cause excessive concentration, make the patient that he is not blinking that much, exacerbating the manifestations of dry eye. Light sensitivity, eye pain or headache, heavy eyelids, eye fatigue. So all these can be manifestations of a dry eye syndrome. So how can you diagnose that? If a patient has any kind of these non-specific manifestations and you wanted to reach a diagnosis, what will be the diagnosis that this patient is complaining of? You need now to do some tests. So how to diagnose a patient with dry eye? First of all, those patients have like abnormality corneal sensation. This can be like hyperesthesia, increasing the sensation, or reduce the sensation. And this may be the result why they have reduced the tear production and reduce the blink rate, because corneal sensation is very essential for tear production and blinking. The trigeminal nerve will affect, or the corneal epithelial health is depending on sensation from trigeminal nerve. So decreasing corneal sensation can result from chronic dry eye. So those patients with chronic or corneal hyperesthesia or reduced sensation may be present in severe and chronic dry eye disease. And corneal sensation can be measured either by cotton tip applicator, or more precisely, and to calibrate the degree of sensation, there is a device called the Cochet-Bonnet esthetometer. So either by cotton tip applicator or by the Cochet-Bonnet esthesiometer. Another more practical way is to that dry eye syndrome will cause abnormal ocular surface, leading to ocular surface staining. More commonly to be measured by the fluorescein staining, so you will find multiple punctate epithelial erosion, more common to be in the interpalpebral region. All this area which is exposed to outer atmosphere will be suffering from punctate epithelial erosion, which will take fluorescein, take greenish stain by fluorescein. Other stains can be used, but less practical in practice of ophthalmology. There is a pinkish stain called rose bengal. This rose bengal also will stain the abnormal ocular surface, and another stain called the lissamine green. So when the ocular surface take any one of these stains, this indicates the presence of dry eye. But let's say we don't have this, or we don't have this kind of corneal sensation measures or ocular surface staining. Any other methods for diagnosis of dry eye syndrome? Yes, there is still more. First of all, by examination of the tear film on a slit lamp. So by just merely examining the tear film on the slit lamp by tear meniscus examination, you can have a clue about the healthiness of the tear film. So the tear film should be continuous like that, slightly concave, and around 1 to 0.1 to 1 millimeter thick. So if you are unable to detect it by just normal examination, you can stain the fluorescein. You will be able to much appreciate it. So it should be slightly concave, as it will be following the concavity of the lid margin. It should be around 0.1 to 1 millimeter thick. Less than that, it indicates a dry eye, and it should be continuous with no interruption. Because if there is any abnormalities in the eyelid, such as if the eyelid margin, the posterior margin, loses its sharpness, this will result in interruption of the tear film. The tear film depends on the sharpness of the lower lid margin in the posterior margin in order to reach the puncti to be excreted. If it is not, as what happens in chronic blepharitis, then it could result in interruption of the tear film and the dry eye. The second test which can be used for dry eye diagnosis is the tear breakup test time. Tear breakup test time, how it is done. So fluorescein is instilled into the eye. So you can see we are installing fluorescein into the eye, then ask the patient to blink several times. So in order to spread the fluorescein all over the cornea. Then by examination by the cobalt blue filter light, we ask the patient to just stand still. We just want the patient to stop blinking and examine the presence of any dark spots. So normally there should be appearance of dark spots, which indicates the break of the tear film over the surface of the cornea. But this break should normally happen after 10 seconds. If it happens less than 10 seconds, when the patient is still fixing his eye or having his eyes not blinking, then this indicates the presence of dryness. That this patient could be complaining of dryness. His tear film is unstable. It just break up very rapidly. It's called the tear breakup test time. So this is another test where we diagnose, or can be used for diagnosis of a dry eye. Another test which can also be used for dry eye, mainly for epiphora, to know how much is if there is epiphora or if there is dry eye. It is called the Schirmer test. What is this Schirmer test? Schirmer test basically depends on the amount of wetting of a special paper called Whitman 41 that is placed into the conjunctival sac to know how much it is wetted by the effect of the tear film. This paper is around 5 millimeter wide and 35 millimeter long. There are two types of this test. One is conducted with local anesthesia. It It's called the Schirmer-1 test, and this will indicate the basic secretion. Because when you are putting this Schirmer paper in the conjunctival sac, it will cause some irritation to the cornea, so it will cause reflex lacrimation. So if we are putting local anesthesia, we will counteract this reflex, or we are canceling this reflex lacrimation. We are only testing the basic lacrimal secretion. It's called the Schirmer-1. Schirmer-1. But if this test is performed without local anesthesia and with nasal stimulation, this will be called Schirmer-2, and it will measure both basic and reflex lacrimal secretion. So do you think, what do you think, which one will be more result, Schirmer-1 or Schirmer-2? I guess that you all agree that it will be Schirmer-2. Schirmer-2 will measure both basic and reflex secretion, so we expect that its value will be more. Yes, exactly, Dr. Hager. So how do we do this test? How to do Schirmer test? We are placing the Schirmer test, the Sherman paper or the Whitman paper in the conjunctival sac. So a filter paper is folded at 5 millimeter. So 5 millimeter are already embedded within the conjunctival sac. So it is folded from the 5 millimeter and inserted into the junction between the middle and the outer 1/3 of the lower lid, like that. Then we ask the patient to keep his eyes closely gentle or gently closed. After 5 minutes, we remove this paper and we now calculate the amount of wetting present in this paper. So you will be able to see how much of this paper is wetted. The result is that it could be either 10 or these numbers 10 and 5 are very important for measures. Like if with anesthesia, it is less than 6 millimeter, this is considered abnormal. So if it is 5 millimeter or less of wetting, this indicates deficient tear film. This indicates dryness. So if with anesthesia is less than 6 millimeter, it is considered abnormal. If without anesthesia, measuring both basic and reflex lacrimation, and it is less than 10 millimeter, again, it is considered abnormal. So again, if with anesthesia is less than 6 millimeter or 5 millimeter or less, it is considered abnormal. If without anesthesia, it is less than 10 millimeter, again, it is considered abnormal. Okay, so this is called the Schirmer test. So this is how we investigate and how we mentioned, Dr. AA, that it is with anesthesia, it is due to the we canceling the reflex lacrimation, but without anesthesia there is reflex lacrimation, so we should put it in mind. So without anesthesia, it will be the reflex lacrimation plus the basic secretion. With anesthesia, it will only count for the basic secretion. So how would we treat a patient with dry eye? Treatment of dry eye syndrome can be depending on the case, the severity of case, whether it is mild, moderate, or severe. We started our treatment by medical therapy, by tear replacement therapy. So those patients receive better to receive preservative-free artificial tears and gel. So preservative-free because sometimes patients can develop toxicity from the preservatives. So this will be better to minimize the toxicity to the epithelium. And the tear form will stay on the eye less time than the gel. So we can modulate our treatment depending on the severity of the case. In order to reduce the evaporization, we can use what's called room humidifiers and moist chamber glasses to reduce topical medications whenever possible. So the excess medications will have excess preservatives causing more irritation to the ocular surface. And if there is any disease that contribute to the inflammation, that if there is underlying ocular surface disease, then this should be managed by topical steroids, cyclosporin, whenever needed. But in some cases, then these management lines will not be enough. So those patients will need surgery like increase the tear retention, some surgical procedures to increase tear retention like punctal occlusure or punctal plugs. So these are the punctal plugs. You can see these punctal plugs are used to occlude the puncti, leading to preserving the tear film in the ocular surface. Okay, so this will be one of the management lines or surgical management lines to the dry eye. Decreasing evaporization. We also, if there is any lid problem, like if there is any lid defect causing tearing or causing lacrimation, then this should be corrected. Okay. Dr. Mary, what is the moist chamber glasses? Well, moist chamber glasses are some prosthetic devices that are coupled to the eyeglasses that slow down the evaporization of tears from the ocular surface. So they are combined to the patient's glasses in order to decrease evaporization. If you just Google them, you will find some pictures and videos for that. So these are some effective and some, yeah, it is best procedure. They are effective, they are safe in relieving the symptoms of dry eye. So yeah, they are very effective. Okay, so some preparations for treatment of a dry eye, depending on viscosity and the frequency. We have some preparation which has low viscosity. They are based on these components, hypermellose and the polyvinyl alcohol. These are the bases. They are instilled every 4 hours or 6 hours. They have preserved form, which is hypermellose and hypotears, and preservative free, such as liquifilm, and Polyfresh and Refresh. These are some eye drops depending on the hypermellose and the polyvinyl alcohol, and they have low viscosity. Other drugs or other medications that have medium viscosity, which are the Carbomar and cellulose. They can be taken 1 time per day up to 6 times, such as Viscotears and Geltears or Celluvesc or Viscotears preservative free, and the highest viscosity will be the paraffins, and they can be taken 1 up to 4 times per day, and they have preservative free forms such as Lacrilube and Lubritears. So these are some preparations for the dry eye management, for medical management of the dry eye syndrome. Okay. So this will be the dry eye. I hope that this topic is clear. And let's now talk about the scleral disorders or scleritis. So we have 2 diseases that are affecting the sclera. One of them is called the episcleritis, which is basically the inflammation of the episcleral tissue. And the other is the scleritis or inflammation of the sclera. So what will be the spectrum of each one? What are the clinical manifestations, diagnosis, treatment, differential diagnosis? This is what will we mention in the next 30 minutes. So scleral disorders, we start by the episcleritis. What is episcleritis? Episcleritis is a common, benign, self-limited cause of dry eye due to inflammation of episcleral tissue. Every word here has its significance. It is a common condition, so you will encounter it very frequently in your practice. It's a benign condition, so it doesn't have complications. It doesn't need surgical interference. It has a good prognosis. It will be self-limited. One of the important causes of a dry eye, and it is caused by inflammation of episcleral tissue. So what are the types? There are 2 types of episcleritis. There is the nodular type, and there is the simple type, or sometimes referred to as the diffuse type. The nodular type is when there is a discrete elevated mass, or sometimes like a nodule, from the inflamed episcleral tissue. You see this yellowish or a yellowish whitish mass, like around 3 mm, with this congested blood vessels. This is an episcleritis, a nodular episcleritis. Another more common form is the simple form or the diffuse form, in which there is vascular congestion, only vascular congestion. It can be either a sectorial, taking a sector, or diffuse, taking the whole episclera. It is just a vascular congestion, flat with no obvious nodule. Okay, so these are the two types of episcleritis. What will be the incidence? Again, incidence is very important in specific disease. One of them is the episcleritis. Episcleritis is a disease which affects the females more common than males. However, there is some query, there is some doubts, some studies that showed that this is only for the middle age or for between 20 to 50 years old. This is the common age for episcleritis. However, it was suggested by some people that it is more common in boys than in girls. So for the younger age group, for boys, it could be more in boys than girls. So if you see this in a sentence in an MCQ, don't say it is wrong, it could be correct. So if you have any other sentence that is more wrong or more that is confusing between that between this sentence and the incidence sentence about incidence in boys and the girls, then remember that here is that there is a query about more incidence in boys. It is more common between 20 to 50 years of old. A simple form is more common than the nodular, and the simple sectorial is more common than the simple diffuse. So simple, more common than the nodular. Simple sectorial is more common than the simple diffuse. Okay, so this is the definition, classification, and the incidence. What about the clinical presentation? How do patients with episcleritis present? It depends on what will be the type, whether it is simple or nodular, because every one of them has its specific course. Simple episcleritis present with acute redness and most commonly with pain, or sometimes it is associated with pain, but it is acute. While the nodular episcleritis, it is less than acute. It will be more gradual redness. So it may be like the nodule is starting to develop. So it may be like gradual redness with pain as well. It could be with pain and or can be without pain, could be with some discomfort or tenderness. And the difference here about the peak. In the simple episcleritis or the diffuse episcleritis, it reaches a peak in 12 hours. So after 12 hours, it will be reach the highest, the maximum redness, congestion, pain, discomfort, and then gradually resolve within 2 to 3 days. While the nodular episcleritis, it is gradually increasing. It will take like few days in order to increase. So the symptoms are progressive. It's becoming even more on awakening in the morning, and there is increase in the redness over the next few days. The simple episcleritis, after resolving, it tends to recur in the same eye or in the other eyes. However, with time, as the patient is growing older, there is becoming less frequent attacks until they disappear completely. So as the patient is growing older, then the frequency of the attack are decreasing. For nodular episcleritis, they are self-limited, so it will also can improve by itself, but the attacks take longer. The attack lasts longer, as we just mentioned. It will take like few days or maybe few weeks until it resolves by its own. Okay, so those patients will present with acute or gradual onset of diffuse or localized eye redness, depending on the type. It is usually unilateral. A bilaterality can be a sign of underlying systemic condition, discomfort, photophobia, or tenderness. If the patient is complaining of severe pain or ocular discharge, then you should consider another diagnosis. Like severe pain can be in scleritis rather than episcleritis. Ocular discharge can be conjunctivitis rather than episcleritis. So this will be, there is diffuse or sectorial, bright red or pink pulbar injection in contrast to the violaceous hue of scleritis. As I'm going to show you right now, the scleritis will not be that red. It can be violaceous or violet in color due to thinning of sclera and appearance of the underlying choroid. So there is a difference in color between episcleritis and scleritis. This one will be one of the differentials. So we said here two differentials between episcleritis and scleritis. One is the pain. The severe pain occur in the scleritis, while in the episcleritis, there will be mild pain or discomfort. And the second thing is the color. The color in the episcleritis, it will be pink or bright red, while in the scleritis, it will be violaceous. Eyelid edema and conjunctival chemosis may be present as well. So what will be the diagnosis? How can we diagnose? We can diagnose by a test called the phenylephrine 2.5 test. Phenylephrine 2.5% test is a vasoconstrictor. So it will tend to vasoconstrict the superficial blood vessels like conjunctival blood vessel and episcleral blood vessels. So it can be used to differentiate between the episcleritis and scleritis. If we have a patient with with red eye and we need to differentiate whether this redness is due to episcleritis or scleritis, we can do the phenylephrine test. If it is blanching, then if the eye becomes white, then this is an episcleritis. If the eye is still red, then this is a case of scleritis. So this will be a test to diagnose or to differentiate between the episcleritis and scleritis. For investigations, do we need investigations to diagnose episcleritis? Actually, no. The episcleritis actually is a clinical diagnosis. However, we need to do it for recurrent cases. So if a patient has the recurrent attacks of episcleritis, those patients could have an underlying systemic condition, or as well, if it is bilateral, those patients could have an underlying condition. So what will be the investigations that we should order? It will be the same like we mentioned in the peripheral ulcerative keratitis. It will be the same collagen diseases or autoimmune diseases. So we do rheumatoid factor, anti-nuclear antibody, uric acid, ESR, C-reactive protein, CBC, the VDRL and fluorescent troponin antibodies, urine analysis, purified protein derivative for TB, chest X-ray, and so you tailor your investigations depending on the history, the review of system, and the examination. But for most of cases, the episcleritis will resolve completely within 2 to 3 weeks. But those who have underlying systemic conditions can have more prolonged course and more recurrence. So what will be the differential diagnosis? The conjunctivitis, as we just mentioned, the discharge. Phlectinular conjunctivitis, we will say the full differential diagnosis from the phlectinular conjunctivitis to the episcleritis. Scleritis, also we will give you a table to differentiate between it. And foreign body granuloma can be sometimes confusing with the nodular type of episcleritis. So when you find a nodule, you may consider this as a nodular episcleritis, but simply it is a foreign body that is impacted into the sclera and causing a reaction or granulomatous reaction around it. So when you do this, you find that you will know by history that the patient has trauma or something that went into his eyes, and those will unlikely to improve by themselves. Those should be by just simple exploration. You will find that there is a foreign body inside this nodule. The treatment of choice for patients with episcleritis are oral non-steroidal anti-inflammatory drugs. So this will be helpful to improve the symptoms and improve the condition. And as I told you, it is self-limited. But to control the symptoms, to control the pain, to minimize the inflammation, oral non-steroidal anti-inflammatory drugs will be the first line. And the topical steroids can be also prescribed just in case if the patient had underlying systemic condition. So those patients can receive topical steroids. So this is for the episcleritis. These are all information regarding the episcleritis. Regarding the scleritis, it is an inflammation of sclera, as we just mentioned, but the presentation is a more different from the episcleritis. It will be like as if they are two different diseases, the episcleritis and scleritis. So scleritis, it is a disease of the inflammation of the sclera that will cause severe pain. This which was not the case for episcleritis. It can cause vision loss. This episcleritis never causes vision loss. So scleritis is a more serious condition. What are the types of scleritis? There are, depending on the anatomical location, it could be either anterior or posterior. So anterior scleritis involving the anterior sclera, posterior scleritis involving the posterior sclera. So which one of them will cause vision loss? It will be posterior, can cause vision loss because of its location. It can be involving the retina, the choroid, the optic nerve. But does this mean that the anterior will not cause vision loss? No, it can also cause vision loss, but in specific types, as I'm going to show you right now. The anterior scleritis, could be non-necrotizing or necrotizing. So it can be associated with necrosis of a sclera, or there is no necrosis. If there is non-necrotizing, it can be diffuse or nodular. The same classification, more or less the same classification like that of episcleritis. Or it can be associated with necrosis, necrotizing, like with inflammation, which will be the most severe type and which will be the most type associated with visual loss and the poor prognosis. And there is without inflammation. So it can be there is necrosis of the sclera without inflammation. So to summarize from this table, we have two main diseases that will cause vision loss, like the anterior necrotizing with inflammation and posterior. Depending on the color, there will be two diseases will be violaceous in color depending on the necrosis of a sclera. So with inflammation and without inflammation, there is necrosis of the sclera, so it will appear as violaceous in color. Okay. Regarding the incidence of scleritis, well, scleritis, it is almost always it will be associated with underlying systemic condition. So it is very, very rarely to occur as an isolation. When you have a patient with scleritis, you should always inquire about systemic conditions. Most commonly is rheumatoid arthritis. So remember when we said that rheumatoid arthritis is the commonest disease that will cause peripheral ulcerative keratitis? Again, we are saying that rheumatoid arthritis is the commonest disease that will cause scleritis. And as almost all autoimmune and collagen diseases, it is more common in females. It is more common in a little bit older age group than episcleritis. So this is again one of the differences. It will be between 40 to 60 years old, or between the fourth and sixth decade. And here is another, as we said in the episcleritis, there is a trick here that the boys could be affected more than girls. And the trick here in the scleritis is that the infectious scleritis are more common in men rather than women. So the autoimmune is more common in women. The infectious, like if a patient has syphilis or so, this will be more in men. Okay. So these are the definitions, classification, and the incidence of scleritis. Let's now see what is the presentation of each one of those types. First of all, the patient has severe pain, very, very important. Severe pain that is boring, that's awaken the patient from sleep. Not many conditions in ophthalmology will cause pain that awaken the patient from sleep. You will hear this symptom by this term: I can't sleep at night from the pain. So this should like enlighten you about scleritis, one of the differentials. So severe boring pain that awaken the patient from sleep and increased by extraocular muscle movement. This is another clue. Why the pain increased by extraocular muscle movement when the patient moves his eyes? This is because of the attachment of extraocular muscle over the sclera. So once the patient moves his eyes, this will result in increasing the pain. So depending on the anatomical type of the scleritis, there will be anterior diffuse scleritis, most commonly anterior diffuse scleritis. So this will be the most common type, the diffuse anterior scleritis and anteroscleral edema. So there will be anteroscleral edema with dilatation of the episcleral vessels. The entire sclera or the just a portion may be involved. So this is a patient with diffuse scleritis, but this is with thinning. So there is underlying with underlying violet color of the underlying choroid is apparent, but this is not for all cases. So this will be like in diffuse scleritis if it is long standing. So just hold on. Okay. So back to the anterior diffuse scleritis, it is the most common, and the anteroscleral edema with dilatation of the episcleral vessels, the entire sclera or the anterior sclera can be affected by the either total diffuse anterior scleritis, or it can take only a portion. The same as we mentioned in the episcleritis. In the anterior nodular scleritis, there will be district nodule, also with scleral edema, and it can be single or multiple and very tender in palpation. So this will be the anterior non-necrotizing scleritis. Could be either diffuse or, hello, can you hear me? Dr. Marwa is saying no voice. Do you hear me? Okay, Dr. Wala here is saying, what are other causes that awaken the patient? Well, there are many reasons for severe pain that could awaken the patient from sleep. It could be like, as we said, anteroscleritis, could be recurrent epithelial erosion, the trigeminal neuralgia, like if the patient has post-herpetic neuralgia. So these are the most common causes. Maybe also congenital glaucoma, acute attack of angle closure glaucoma will cause severe pain. So this severe pain, the patient doesn't always happen in many ophthalmic conditions. As I told you, scleritis, angle closure glaucoma, recurrent epithelial erosion, severe keratitis, trigeminal neuralgia, all these can be causing this presentation. Back to the scleritis, the anterior nodular scleritis, it is, as we said, there is a district nodule of scleral edema and could be single or multiple tender on palpation. Anterior necrotizing with inflammation, this is the most serious part. This is the most severe. You see how much is the necrosis of the sclera? There is severe necrosis of the sclera. There is severe pain with extreme scleral tenderness. Those patients are associated in many occasions associated with vasculitis. So those patients have vasculitis causing like ischemic infarction of different parts of the body. And also it will cause ischemic infarction in the sclera. So causing infarction with necrosis and exposure of the choroid, usually those patients, this is a very poor prognostic sign. Like those patients will, like around 50% of those patients will die from the underlying systemic condition within 5 years. So this indicates the severity of the systemic condition. It's called the anterior necrotizing with inflammation. And by the way, it is not only can happen from the systemic conditions, but it also can happen with some surgeries, like doing like tracheum surgery. Some surgeries can result in severe scleral thinning or can induce this kind of inflammation, anterior necrotizing scleritis with inflammation. The surprising thing is there is another entity of anterior necrotizing scleritis, but without inflammation. It looks like the same, but with white eye. So there is scleral thinning and there is scleral necrosis. That's why it's called anterior necrotizing scleritis, but without inflammation. So the sclera is white. There is no redness, there is no pain. Is sometimes or usually it is discovered accidentally. So the patient is coming for routine checking or for glasses, and you discover this marked thinning. This is sometimes referred to as scleromalacia perforans. This is the other name of this disease. It is more common in females, more common in rheumatoid arthritis, and there will be a choroidal exposure, staphyloma may happen in those patients. Okay, so these are the different presentations of anterior scleritis. I hope that this is clear. It can be either necrotizing or non-necrotizing. The non-necrotizing can be diffuse or nodular. The necrotizing can be with inflammation or without inflammation. The other entity is the posterior scleritis. The manifestations of posterior scleritis can be combined in the word post-scler. So each letter will count for a specific symptom or sign. P for proptosis. Those patients can present with proptosis from posterior scleritis. They could have ophthalmoplegia. Ophthalmoplegia meaning that there is limitation of ocular movement. Can be also due to posterior scleritis. They will have swelling of the optic disc. It is one of the differential diagnoses of optic disc swelling. And thickening of the sclera, which appears on ultrasound and CT. So you can see here, this is the ultrasound showing what's called characteristic T sign. T sign because of the thickening of the sclera with the fluid in the subtenon space, together with the shadow of the optic nerve. All these will form the letter T. So letter T will be that like the how does this disease appear in the ultrasound. Also, it can be present on the CT scan. You can see the CT scan differences between the both eyes. You can see that the sclera is markedly thickened in this this eye, in the right eye. This is the right eye compared to the left eye. So again, P for proptosis, O for ophthalmoplegia, S for swelling of the optic disc, T for thickening of the sclera by ultrasound and CT, and sclera, S for subretinal exudates. So those patients can have subretinal exudation. This is also one of the differential diagnoses of exudative retinal detachment. C for or F for or L for choroidal folds. So folds is for L. Choroidal folds is one of the differential diagnoses of choroidal folds is the posterior scleritis. Can also cause excessive retinal detachment, as I just mentioned to you, and can cause also ring choroidal detachment. Ring choroidal detachment. So these are the manifestations of posterior scleritis. So it is obvious that it will affect the vision tremendously. Optic disc swelling with subretinal exudation, folds, exudative detachment, choroidal folds, all these can result in affection of the vision. So what the treatment and investigations and the treatment of posterior scleritis are the same like the most serious part of anterior scleritis, which is the necrotizing with inflammation. All what happens or what goes with the anterior scleritis, anterior necrotizing scleritis with inflammation will go also with the posterior scleritis. So how would we diagnose? Again, how would we differentiate it? Differentiate scleritis from the episcleritis? It will be by the phenylephrine test, as we just mentioned. It will cause blanching of the conjunctival and episcleral vessels, but leave the scleral vessels undisturbed. So this will be a differentiating feature. investigations here are usually needed. So it is unlike the episcleritis, we need the investigations in such condition. For scleritis, we need to know what will be the underlying systemic conditions. Differential diagnosis, the main differential diagnosis will be the episcleritis, and the treatment will be depending on the case. Like the first line in mild to moderate scleritis, it will be the oral non-steroidal anti-inflammatory drugs, but usually they are not sufficient. So again, there is remember there is a difference between a first line and the full treatment. It is a first line, but doesn't have to be sufficient for all cases. So we start in the mild to moderate scleritis, we initiate the treatment by oral steroids, oral non-steroidal anti-inflammatory drugs. Topical steroids, I'm stressing on this for MCQs. Topical steroids could have a role. Yes, they could have a role. But if we are comparing between which one to give, whether oral non-steroidal or topical steroid, it will be the oral non-steroidal. Topical steroids are contraindicated? No, they could have a role. They can decrease inflammation. But the main treatment is systemic. So which is better, topical steroid or systemic steroids? It will be systemic steroids. This will be the better, because systemic steroids will control the underlying autoimmune process. Also, for most of cases of scleritis associated with systemic conditions, they will need immunomodulatory medications. So these are immunomodulatory medications that are, all most cases or most autoimmune diseases have its each one will have its specific preferred drug or preferred autoimmune medication. Like for example, for rheumatoid arthritis, those patients respond well on methotrexate. Patients with Wegener granulomatosis or the granulomatosis with polyangiitis, they will respond well on cyclophosphamide or mycophenolate. Cyclosporin can be also used. Mycophenolate mofetil also can be used for patients who have problems with the steroids or where the steroids are contraindicated or they are complicated. This should be treated in conjunction with the rheumatologist and the immunologist. Okay, so this is the medical management. We said that there is no surgical management for episcleritis, but for scleritis, there is a surgical management. Like if there is severe necrosis, which will expose the ocular tissues, it will cause exposure of the underlying choroid, then we can reinforce the sclera by a scleral patch graft. For case of severe thinning or if there is a perforation, so we can do the sclera, we can do this scleral patch graft. Dr. Maria, does this classification for scleritis have any name? No, it is just a classification. I don't know what is meant by a name. It is a classification of scleritis into anterior and posterior, and anterior into diffuse, into non-necrotizing and necrotizing, and then necrotizing into without inflammation, and the non-necrotizing into diffuse and nodular. So what is meant specifically by a name? You mean like any scientist name? Society? No, I am not aware of that. Have you read it in anywhere? What is the classification, Dr. Maria? What is the classification that you have? Can you please share it with us? Yeah, sure. Let me just please raise your hand. Okay, you have the mic.
Sorry, I'm Dr. Atif. Actually, that's my daughter's name. What classification that I have, it also does not have any name, but it is divided in scleritis into anterior and posterior, and anterior is further divided into non-necrotizing and inflammatory and non-inflammatory. Okay, this the non-inflammatory is again divided into diffuse and nodular, and inflammatory is divided into necrotizing and non-necrotizing, which is also known as scleromalacia perforans.
So it is
So
the
this
same
is the
thing. It's the same thing. It is just that they put the word inflammatory in order to indicate the presence of necrosis or not. So this doesn't add anything new for the classification, but thank you for the information.
okay.
Okay, so these are the management of scleritis. So again to put more spotlight on the differences between the episcleritis and scleritis. The episcleritis is an idiopathic inflammation, while the scleritis is usually characterized by autoimmune dysfunction. So those patients have underlying systemic condition. Symptoms of episcleritis with acute onset, mild pain, redness, irritation. Scleritis are present with subacute onset, severe pain, pain with eye movement, blurred vision or vision loss, photophobia. The physical examination in the episcleritis, they will be mobile vessels, so they will show mobility. Blanch with phenylephrine drops, and they will be more reddish, more red in color, bright red. The scleritis are the blood vessels, the dilated blood vessels are more adherent, so they don't, if you are trying to move them with a cotton tip applicator or so, they will not move. They doesn't blanch with phenylephrine drops. They will show bluish or purplish violaceous hue. Slit lamp may show nodules, scleral thinning, some corneal changes if the patient has rheumatoid arthritis and associated with peripheral ulcerative keratitis. Systemic inflammation associated with peripheral ulcerative keratitis or with other autoimmune diseases such as joint pain, rash, and so on. Treatment for episcleritis, it is self-limited. And for you only consider steroids for the refractory cases. So the first line will be the non-steroidal, and you just add topical steroids for refractory cases. For scleritis, they will need consultation. They will need rheumatologist consultation and immunologist consultation. The treatment should be with systemic steroids and non-steroidal anti-inflammatory drugs. So depending on the case, so if it is mild or moderate, we can start by non-steroidal. But for most cases, usually they are severe, so we should start also systemic steroids with or without topical antibiotics or topical steroids, and we also consider systemic immunomodulatory medications. Differences between the nodular episcleritis and the flectin. I brought this table because one of you asked about me yesterday. So how would we differentiate between nodular episcleritis and the flectin? Both of them can be confusing. So depending first about the incidence, the nodular episcleritis is more common in the older age group, as we just mentioned, between 30 to 50 years old, while the flectin is more common in children. Sex in the nodular episcleritis more common in females, while flectin more common, it is equal in males and females. Nodular episcleritis can be long history. They will have history of recurrent attacks, and this can happen in the past, while flectin doesn't show this long history. Signs, so the site in the nodular episcleritis, it is away from the limbus, but the flectin more common at the limbus. The color, it will be the nodular episcleritis. It can sometimes be purple with deep vessels, but flectin will be grayish. The level in the nodular episcleritis, it will be subconjunctival or deep, while in the flectin, it will be conjunctival, so it appears superficial. The movement, the nodular episcleritis is fixed to the sclera, and the conjunctiva moves over it. This is very important. when you try to move this nodule, you will find that it is fixed. It is a part of the sclera. It is the episclera. And the conjunctiva is freely mobile over it. In the flectin, when you try to move the conjunctiva, the mass or the flectin will move with it or will move with it. The tenderness, the nodular episcleritis can be very tender, but the flectin not tender. The ulceration in the nodular episcleritis never occur, but the flectin, it occurs. You remember the photo I showed to you, the flectin with surface ulceration and taking the fluorescein stain. The suppuration, there is no pus here in the nodular episcleritis, but in the flectin, it can suppurate or can show inflammation with suppuration. Complications, nodular episcleritis can be complicated by scleritis, especially if there is underlying systemic condition, but this is rare. In the flectin, there are common complications that will involve the cornea with corneal neovascularization and scarring, as we mentioned yesterday. Prognosis, depending on the etiology, but it is usually benign in the nodular episcleritis, but it can be serious depending on the cause if there is systemic condition. But the prognosis in the flectin is usually good. They usually respond well to the topical steroids. Okay, so these are the differences between the nodular episcleritis and the flectin. Dr. Hagar, the center is red where? What is meant by the center is red where? Didn't understand your sentence. The center of the nodule, which nodule, in the episcleritis or the scleritis or the flectin? Okay, here is the nodular episcleritis. Sometimes the color is purple in the if there is deep vessels. So if there is deep vessels showing congestion, it can appear as purple. But the red, it is generally red. Like the episcleritis, when it is diffuse, it is generally red. The nodular, it can be reddish rounding the nodule, but the nodule itself could be more purple. So to summarize, we have the episcleritis and scleritis. Episcleritis can be either diffuse. You can see this is the diffuse episcleritis. And this is the nodular episcleritis. You can see that the nodular episcleritis doesn't have to be reddish. The nodule itself is not reddish. It can sometimes be yellowish, can sometimes be purple, depending on the color and or depending on the dilatation of the underlying blood vessels. And the scleritis can be anterior or posterior. The anterior can be non-necrotizing or necrotizing. Non-necrotizing can be diffuse. You can see this is a diffuse scleritis. This is a nodular scleritis. This is a necrotizing scleritis with inflammation. And this is a necrotizing scleritis without inflammation. Okay. Finally, last thing is the differential diagnosis of blue sclera. So the blue sclera, we can summarize it in the word Hope's belief. So if you are asking in the exams about all these can cause blue sclera except, it will be H for high myopia, O for osteogenesis imperfecta, P for pseudoxanthoma elasticum, E for Ehlers-Danlos syndrome, S for scleritis. So scleritis will cause thinning of sclera and exposure of the underlying choroid, leading to the bluish color. Then B for ophthalmos. So we only take this letter B from belief. Hope's belief, B for ophthalmos. So these diseases will usually cause stretch of the eye, enlargement of the eye for the high myopia and the osteogenesis imperfecta, pseudoxanthoma elasticum. They will have abnormal collagen of the sclera or stretch of the eye. So they will cause exposure of the underlying choroid, leading to appearance of bluish color. So these are the causes of blue sclera. Okay, so these are the dry eye and scleritis. So we took like 1 hour, as I told you. We will now move to the lens. So as I told you, we will just postpone the surgery to the next lecture. It will be better to combine all the surgery in one lecture for better time.